All right, team, welcome. This deep dive is specifically for you, our radiography students.
Yep, right smack in the middle of your radiographic pathology course.
We've taken your source material, those PowerPoint slides on the hematopoietic and endocrine systems, and we're pulling out the key stuff.
The absolute must-knows.
Yes, exactly. Think of this as less textbook, more practical insight.
Right. Our goal today is to really unpack these systems, figure out the important concepts, and crucially, link it all back to what you'll actually see on your images.
Yeah, how does this stuff look on an X-ray or a CT? That's the key, right?
Absolutely. Consider this your guided tour, connecting the biology to the pathology you'll encounter.
We know it can seem dense, but we promise to make it clear, useful, and hopefully kind of interesting.
Should we jump in?
Let's do it. First up, the hematopoietic system.
Okay, so in simple terms, what's its main job?
Its main gig, it's the body's blood cell factory. Simple as that.
Blood cells. So, red blood cells, white blood cells, platelets.
You got it. All produced here.
And where's your... Exactly.
Primarily the red bone marrow. That's the main site for red blood cells and platelets.
Okay, red marrow for those two. What about white blood cells?
White blood cells are a bit different. They're made in the red marrow and also in lymphoid tissue.
Gotcha. So, red blood cells, or erythrocytes. They carry oxygen, right, because of hemoglobin.
Exactly. Hemoglobin is like the critical component inside the red cell. It grabs onto oxygen in the lungs and carries it everywhere else.
Like little oxygen taxis.
Perfect analogy.
Right.
And the white blood cells, leukocytes. They're the defense force.
The immune system crew.
Right. You've got neutrophils. They're like the first responders, eating up bacteria.
Phagocytosis.
Okay. Then eosinophils.
They deal more with allergic reactions and parasites.
Right. And lymphocytes.
Lymphocytes are key for the adaptive immune system. Think antibodies, immune memory.
And monocytes.
Also phagocytic like neutrophils, but they're involved in cleaning up debris and inflammation too. Big picture.
Yeah.
There's all about immunity. Okay, makes sense. So that's the normal setup. What happens when the red blood cell side goes wrong?
Well, the big one everyone knows is anemia.
Right. Anemia just means less oxygen getting around.
Essentially, yeah.
Yeah.
It's a decrease in that oxygen-carrying hemoglobin. Your sources list a few types to know.
Okay, like what?
There's iron deficiency anemia, super common, often from slow chronic blood loss. Hemolytic anemia, where the red cells just don't live as long as they should. They break down too fast.
Okay, shortened lifespan.
Megaloblastic anemia, that's usually a vitamin B12 issue. Aclastic anemia is serious. The bone marrow basically shuts down production.
Wow, okay.
And myelophasic anemia, where something else like cancer cells invades the marrow and pushes out the normal production.
Got it. Now, you mentioned hemolytic anemias. The source material digs into some specific hereditary types, right?
It does, and these have visual clues for you guys,
Mm-hmm.
like spherocytosis.
Spherocytosis.
Sphere-shaped cells. Exactly. Instead of nice flexible discs, the red cells are like little balls. They get trapped and destroyed easily, especially in the spleen.
So sometimes removing the spleen helps?
Yep, splenectomy can actually be curative in some cases. Pretty neat.
Okay. What else?
Then there's sickle cell anemia. Primarily affects people of African-American descent.
And the source says this one has clear radiographic signs.
Absolutely. This is key. The red cells sickle, they change shape, become rigid, they clog up small blood vessels.
Which damages tissues.
Right. Bones are commonly affected. You might see bone infarcts, areas where the bone tissue died from lack of blood.
Yeah.
Or that classic H-shaped vertebra on a spine image. The pathology directly causes these visible bone changes.
Wow. Okay. Really direct link there.
And the one your source says has the most severe radiographic changes. That's thalassemia.
Thalassemia, more common around the Mediterranean.
Yeah, think Italian, Greek, Sicilian populations especially. The body can't make proper hemoglobin.
So the marrow goes crazy trying to compensate?
Exactly. It expands massively. This actually remodels the bones. You can see changes in the skull, like a hair-on-end appearance, or facial bone deformities on radiographs. Seeing that kind of extreme marrow expansion points you towards thalassemia.
Okay, that's a very distinct radiographic picture.
Definitely. Now, flipping the script, what if you have too many red cells?
That's polycythemia. Increased numbers of red cells, granulocytes, platelets too.
Right. It can be primary. The bone marrow itself is just overactive. Hypoplasia.
Or secondary.
Yeah. Secondary polycythemia is the body reacting to chronic low oxygen.
Like someone with severe lung disease.
Yeah.
Or living at high altitude.
Precisely. Or certain congenital heart diseases. The body senses low oxygen and thinks, need more carriers. so it cranks out more red blood cells.
Makes sense as a response, even if it's problematic. Okay, let's shift to white blood cells. What's the big issue there?
Leukemia.
Cancer of the white blood cells.
Yep. Two main flavors mentioned. Myelocytic, which starts in the bone marrow itself.
Cancer of the granulocytes, basically.
Right. And lymphatic leukemia, which is more a malignancy of the lymph nodes, leading to tons of lymphocytes.
And the problem isn't just the cancer cells themselves, right? It's that they take over.
Exactly. You get this massive overproduction of abnormal white cells, and they crowd everything else out.
So you end up with anemia because there's no room for red cells, and bleeding problems because platelets get squeezed out too.
Precisely. It causes secondary problems.
Okay. And related to that, lymphoma.
Right. Lymphoma isn't leukemia, though they're related. Lymphomas are cancers of the lymphoreticular system.
So lymph nodes, the spleen, lymphoid tissues, elsewhere.
Yep. Hodgkin's and non-Hodgkin's are the two major categories you hear about.
And here's another one, the source flags for imaging, isn't it? A key radiographic finding.
Absolutely critical takeaway. The most common radiographic finding in lymphoma. Enlarged mediastinal lymph nodes.
Right there in the middle of the chest, around the heart and airways.
You see those big bulky nodes on a chest x-ray, or especially a CT. Lymphoma has to be high in your list. That's a visual pattern you need to burn into your brain.
Definitely. What about mono? Infectious mononucleosis.
Ah, the kissing disease. It's a viral thing, usually Epstein-Barr virus messing with the lymph system.
Causes fatigue, sore throat, swollen nodes. Pretty vague stuff.
Yeah, mostly affects young adults. You probably won't do specific imaging for mono, but you might incidentally see those swollen lymph nodes on a scan done for other reasons.
Good point. Okay, last part of hematopoietic. Platelets. Their job is clotting, right?
Yep, stopping bleeding. So if clotting goes wrong,
Hemophilia.
that's the inherited one. Mostly seen in males that's sex-linked. They lack a specific clotting factor, usually factor 8.
Meaning they bleed easily?
Yeah.
Spontaneous bleeds, bad bleeding after injury.
Exactly. And for imaging, the key thing the source mentions is the joint damage.
From bleeding into the joints over and over.
Precisely. Recurrent hemarthrosis, bleeding into the joint space, causes inflammation, damages cartilage, erodes bone. So on an x-ray, you're seeing the chronic effects. Joint space, narrowing, erosions, maybe even deformities. You see the consequences of the bleeding.
Got it. Not the bleed itself, but the damage it leaves behind.
Right. Then there's purpura, also called thrombocytopenia.
Thrombocytopenia, low platelets. Purpurea meaning deficiency.
You got it. Low platelet count.
Right.
Could be decreased production, increased destruction. Lots of causes.
And the result is easy bruising, spontaneous bleeding.
Yeah, under the skin, in mucous membranes, even internal organs.
And the source mentions a specific GI finding here.
Yes, this is really specific and cool. For certain types of purpura, especially idiopathic thrombocytopenic purpura, ITP, if there's bleeding into the wall of the small bowel.
Okay.
On imaging, like a barium study or CT, you see this characteristic uniform, regular thickening of the mucosal folds. Think of the folds inside the intestine looking really plump and evenly spaced.
Like stacked coins almost.
Exactly. That stacked coin appearance is a unique sign you might see, directly caused by hemorrhage into the bowel wall from low platelets. Pretty neat visual tie-in.
Definitely a good specific pattern to know. Okay, so that wraps up the hematopoietic system, blood cells, clotting, and what goes wrong visually. Ready to switch gears?
Let's do it. Moving on to the body's chemical signaling network, the endocrine system.
Right, this is all about hormones. Glands secreting chemicals that travel through the blood to tell other organs what to do.
Like a biochemical communication system. We're focusing on the big players mentioned in your slides. Pituitary, adrenal, thyroid, and parathyroid glands.
And hormones are just those chemical messengers, right? Different types of proteins, steroids.
Yep, affecting specific targets or sometimes the whole body.
Okay, where should we start? Adrenal glands.
Sounds good. The little gland sitting on top of the kidneys. Two parts, medulla inside, cortex outside.
The medulla, that's adrenaline, right? Fight or flight.
Exactly. It secretes epinephrine, adrenaline, and norepinephrine in response to stress. Gets your heart pumping, blood pressure up, releases glucose, prepares you for action.
Okay. And the cortex, the outer layer.
Makes a bunch of other crucial hormones, corticosteroids. When the cortex has issues, you see diseases like Cushing's syndrome.
Too much cortisol, basically.
Right. Excess glucocorticoids. Different from Cushing's disease, which is pituitary-driven, but similar effect. Then there's aldosteronism.
Overproduction of aldosterone. That affects blood pressure.
Yep, messes with sodium and potassium balance, leading to hypertension.
Okay. What else from the cortex?
Adrenogenital syndrome, which affects sexual development. Can cause issues like accelerated growth, then early closure of growth plates in kids, or masculinization in women if acquired later.
And the opposite, not enough hormone.
Hypoadrenalism or adrenal insufficiency. The primary form is Addison's disease.
Got it. Can the adrenals get cancer?
They sure can. Adrenal carcinoma is a primary malignancy. Interestingly, about half of them are functioning tumors.
Meaning they pump out hormones.
Exactly. Causing Cushing's or virilization or aldosteronism because the tumor itself is making the hormones. They tend to grow fast and can be quite large and necrotic when found.
And what about cancer spreading to the adrenals?
That's actually really common. The adrenals are one of the top spots for metastasis.
From where? What primary cancers like to go there?
Your source lists the big ones: lung, breast, kidney, ovary, GI tract cancers, and melanomas. So if you're scanning a patient with one of those cancers, you definitely need to check the adrenals carefully for mets.
Good clinical point. Okay, back to the medulla, the inside part. Any tumors there?
Yep. Pheochromocytoma, usually benign, but it's a tumor of the medulla cells that make epinephrine or reponair.
So it produces excess adrenaline-like hormones.
Right, excess vasopressors. Causes wicked hypertension, but is often curable if you find and remove the tumor. Your sources mention CT and ultrasound are good for spotting these.
Okay. And there's another important medulla tumor, especially in kids.
Neuroblastoma, highly malignant tumor of the adrenal medulla. Sadly, it's the second most common malignancy in children.
And it gets big before being found.
Often, yes. And here's a super important imaging pearl for you. Neuroblastomas frequently have calcifications within them.
Calcifications?
Yeah.
Little white specks on X-ray or CT?
Exactly. Seeing those calcifications is a huge clue. It helps differentiate it from another common pediatric abdominal mass, the Wilms tumor, which arises from the kidney and typically doesn't calcify like that.
Ah, so that calcification pattern is key for diagnosis.
Very key. And unfortunately, neuroblastoma likes to metastasize often to bone, liver, and lungs.
Okay, that's a lot for the adrenals. Let's move up. Pituitary gland, the master gland.
Yep, sitting right under the brain in that little bony pocket, the sella turcica. It controls so many other glands, but it gets its own orders from the hypothalamus.
It has two parts, right? Anterior and posterior lobes.
Correct. Different hormones from each. Anterior lobe makes things like growth hormone, GH, TSH to stimulate the thyroid, ACTH for the adrenals.
The gonadotropins, FSH and LH for reproductive stuff?
Yep, and prolactin for milk production.
Mm.
Lots going on in the anterior pituitary.
Okay, posterior lobe.
Simpler, just two main ones. Vasopressin, also called ADH, antidiuretic hormone.
That's the water balance one. Tells kidneys to conserve water.
Exactly, protects you from dehydration. And oxytocin.
Oxytocin, involved in labor, uterine contractions.
Yep, causes smooth muscle contraction, important for labor and preventing bleeding afterwards.
Okay, so diseases of the pituitary often involve too much or too little hormone.
That's the main theme. Hyperpituitarism, usually too much growth hormone.
What does that cause?
Depends on when it happens. In kids whose bones are still growing, it causes gigantism. They just get incredibly tall.
And in adults, after bone growth stops.
It causes acromegaly. Bones can't get longer, but they get thicker, wider. Soft tissues enlarge, too. Leads to characteristic coarse facial features, big hands and feet.
And there's a specific radiographic sign for acromegaly.
There is. Your source highlights this. Measure the heel pad thickness on a lateral foot x-ray. If it's thicker than 23 millimeters, that's a classic sign suggesting acromegaly due to that soft tissue overgrowth from excess GH.
Wow, a simple measurement with big implications.
Definitely something to keep in your back pocket. The flip side is hypopituitarism.
Too little hormone.
Right. In kids, this can cause dwarfism. They fail to grow in height and sexual maturation is delayed, but they're usually normally proportioned and have normal intelligence.
Just overall small stature due to lack of GH and other hormones?
Correct. Then there's diabetes insipidus.
You mentioned this isn't related to sugar diabetes.
Not at all. Different mechanism entirely. This is about water. Either the pituitary isn't making enough ADH, vasopressin, or the kidneys aren't listening to the ADH that is there.
So the kidneys don't get the signal to conserve water.
Right. They just dump massive amounts of dilute urine, leads to severe dehydration if water intake doesn't keep up.
Okay, got it. Let's move to the thyroid gland in the neck.
Butterfly-shaped gland sits right below the Adam's apple, two lobes connected by an isthmus.
And it makes thyroid hormone, T3 and T4. Controls metabolism.
Yep, thyroxine sets the body's metabolic rate, affects how fast your cells burn energy, influences digestion, heart rate, body temperature, pretty much everything.
So problems here. Nodules. Lumps in the thyroid.
Very common. They can be hot, meaning they're overproducing hormone, or cold, meaning they're underactive or non-functional.
And nuclear medicine scans are best for figuring that out.
Often, yes.
Oh,
The scan shows how much radioactive iodine the nodule takes up. Hot nodules take up a lot, cold ones don't. Helps determine if it's suspicious for cancer, as cold nodules carry a higher risk.
okay. Then hyperthyroidism. Too much hormone.
Right. Makes everything speed up: weight loss, rapid heart rate, anxiety, feeling hot. Graves' disease is when the entire gland is overactive.
And hypothyroidism. Too little hormone.
Everything slows down. Weight gain, fatigue, feeling cold, depression. If it's congenital present from birth, it's called cretinism.
Cretinism has specific features.
Yeah, the source lists them. Short stature, coarse facial features, protruding tongue, broad flat nose, sparse hair, dry skin, big belly, often with an umbilical hernia, all due to severely slowed metabolism from birth.
Okay. What is a goiter?
A goiter is just an enlarged thyroid gland. It doesn't automatically mean cancer or hyperthyroidism, though it can be associated. It's just swelling.
Used to be common due to lack of iodine.
Exactly. The gland swells up, trying harder to capture the little iodine available to make hormone. You might see a large goiter on a chest or neck x-ray, maybe pushing the trachea to one side.
Right. Benign tumors?
Radiomas?
Yep, thyroid adenomas are benign encapsulated lumps. They can grow large enough to compress nearby structures, like the trachea, and sometimes they develop calcifications within them.
Seeing calcification in a thyroid mass on imaging could be a clue.
Could be. And then there's thyroid carcinoma, actual cancer.
3 main types mentioned.
Capillary is the most common. Follicular, often women over 40.
Okay.
And medullary, which is the rarest.
Okay. Tucked behind the thyroid, the parathyroids. 4 tiny little glands usually. Super important job, though.
They make parathormone, PTH, controls calcium.
Bingo. PTH is the main regulator of calcium and phosphate levels in the blood. Critical for nerve function, muscle contraction, bone health.
So hyperparathyroidism is too much PTH.
Right. Leads to high blood calcium, hypercalcemia, and low blood phosphate. It pulls calcium out of the bones, making them weaker.
Different causes, primary, secondary.
Primary is usually a tumor or overgrowth, hyperplasia, of the parathyroid glands themselves. Secondary is more common, often linked to chronic kidney failure.
Why kidney failure?
Failing kidneys can't get rid of phosphate properly, and they don't activate vitamin D well.
Yeah.
Both mess up calcium balance, triggering the parathyroids to constantly pump out more PTH in response. Tertiary is when this becomes autonomous, even after kidney issues are addressed.
Got it. And hypoparathyroidism, too little PTH.
Usually happens accidentally, like if the glands are injured or removed during thyroid surgery.
And low PTH means low calcium. What does that cause?
Low calcium makes nerves and muscles hyperexcitable, leads to tetany, sustained muscle contractions, cramps, numbness, tingling, can even cause spasm of the larynx muscles, which is a medical emergency.
Okay, scary stuff. Finally, let's link the pancreas into the endocrine system via diabetes mellitus.
Right, though the pancreas has digestive functions too, its endocrine role is making insulin. Diabetes is incredibly common.
And it's basically a problem with insulin, right? Either not enough or the body doesn't respond to it.
Exactly. Insulin acts like a key, letting glucose, sugar from food, enter your cells to be used for energy.
Without that key working properly, glucose piles up in the blood.
Yep, hyperglycemia. The cells are starved for energy even though there's plenty of sugar around, and the high blood sugar causes damage over time.
And the complications are where imaging often comes in.
For sure. The source lists major ones. Atherosclerosis, hardening of the arteries, which increases risk for heart attack, stroke, and poor circulation leading to gangrene. You'll image these conditions.
Infections are common too. Poor healing.
Yep. Bad circulation makes healing tough. Kidney damage leading to failure is a huge issue. You might do renal ultrasounds or other scans. Blindness from damage to retinal blood vessels.
And nerve damage.
Neuropathy. Pain, tingling, numbness, sometimes even paralysis due to poor circulation affecting the nerves.
Okay, lots of systemic effects. And there's one more critical point for techs about diabetic patients.
Yes, absolutely vital and straight from your source material. Watch out for insulin shock or hypoglycemic shock.
Low blood sugar.
Dangerously low. It happens if a diabetic patient takes their usual insulin dose, but then doesn't eat, like if they're NPO, nothing by mouth, for a procedure you're involved in, or if they exercise too much.
So their insulin drives their sugar down, but there's no incoming sugar from food.
Precisely. Their blood sugar crashes. You need to recognize the signs: shaking, sweating, confusion, irritability, maybe even loss of consciousness.
And as a tech, you need to act fast.
Immediately. Alert a nurse or physician. This is a medical emergency. Knowing to look for this, especially in NPO diabetic patients, is part of safe patient care. It directly relates to understanding this endocrine disorder.
Wow, okay. That is really crucial practical knowledge.
So that covers a huge range, from blood cell production and clotting.
All the way to hormone signaling, controlling metabolism, stress response, growth, calcium, and sugar levels.
We've hit the major pathologies in both the hematopoietic and endocrine systems.
And the big takeaway, hopefully, is seeing how these diseases aren't just words in a textbook. They cause real physical changes.
Changes that you, as radiography students, will learn to see and recognize on your images.
Right. Bone changes in sickle cell or thalassemia, those big mediastinal nodes in lymphoma, joint damage in hemophilia, that thickened heel pad in acromegaly, the calcified neuroblastoma.
The thickened bowel folds in purpura. The list goes on. These are the visual fingerprints the pathology leaves behind.
And understanding the why behind those signs, the pathophysiology, makes you so much better at interpreting what you see.
It elevates you from just taking pictures to actually understanding the story those pictures tell about the patient's health.
Exactly. It's about connecting those dots between the disease process and the image findings.
So, our advice, keep digging into this stuff. Revisit those lecture slides.
Yeah, don't just memorize. Try to understand the connections. Study regularly. Make it stick.
And don't forget, you can always find extra resources, study tips, and just general radiographic coolness over at the radiologic.technologist.com.
Yep, your instructor keeps that blog packed with useful info. Definitely worth checking out.
Keep up the great work. Keep studying.
You're building a really important knowledge base.
And maybe think about this next time you pull up an image. Are you just looking at shadows and densities, or are you starting to see the underlying physiology and pathology whispering clues to you? That's the goal.
Well said. Until our next deep dive, keep learning.